Okay, hello. In our meeting today, it's about 10 o'clock, so I'm just going to go ahead and get started. So in our WebEx today, we're going to cover some ICD-10 coding guidelines. So you'll be in your ICD-10 manual again, and we're just going to keep going through the guidelines until we cover them. And in this WebEx, we're going to be looking up a couple things and examples. So if you have your ICD-10 and a highlighter, and a notepad to write notes that you might want to transfer into your manual later, that's a good idea. So I'm sharing my screen, and you can see that I'm in the ICD-10 guidelines. So don't pay attention to the page numbers in this, because the page numbers aren't going to reflect the page numbers in your manual. But if you go to the ICD-10 guidelines and you go to section B, General Coding Guidelines, and in the last WebEx, we covered section A of the coding guidelines, so this is just flowing right along. So we're in section B, general coding guidelines, and my screen is just black and white. It's just taken off of the CMS website, these guidelines. So your book is gonna look a little bit different, but it's going to cover it verbatim. So under B, general coding guidelines, number 1, we see locating a code in the ICD-10 CM. So this is going to tell us the proper way to look up a code. You're going to learn that for the exam purposes, you're not necessarily going to be properly looking up codes every time because of the time that takes. But it's still very important for you to know that how you look up a code. So to select a code in the classification that corresponds to a diagnosis or a reason for a visit documented in the medical record, first you locate the term in the alphabetical index, and then you verify the term in the tabular. So basically what that means in plain English is when you're going through a medical record and you see a diagnosis and you need to code it, you're going to take that term, that diagnosis, you'll start in your index, which we've labeled, we've tabbed our index if you remember, and you're going to verify the term in the index, and then you're going to look at the page number that it directs you to in the tabular. Then you flip on over to your tabular and you verify the code there. And that's important because in the tabular, it's going to give you more information about that code. So whether additional codes need to be coded with it, what codes can never be coded with it, and different tips as you've seen throughout your book. So that's the simple way to look that up. And then it talks a little bit about it's essential to use both the index and the tabular when locating and assigning a code. And that's true for maybe some one-off diagnosis. So once in a while, the only way you can get to a code in the tabular is by using the index if you're given the code, because there'll be some unusual wording. But most of the time, if you actually have the code in front of you for like the exam for test taking purposes, they're going to give you those 4 multiple choice answers. So you'll have 4 different codes already. You don't have to verify by looking up a term, and you would just go to the tabular to save time. And we'll get into that when we start covering test taking practices. And it explains that a dash at the end of the alphabetic index term indicates that more characters are required. So if you're looking up a code in your index and you see a dash at the end of it, it's just saying this is not a complete code. You need to go to the tabular and figure out what additional digits are needed. Our next section under B2, level of detail in coding. So diagnosis codes are to be used and reported at the highest number of characters available. So basically all that's telling us is that we definitely need to report to the highest specificity. So the diagnosis codes are composed of codes with 3, 4, 5, 6, or 7 characters. And if a code has 3 characters behind the heading of a category of codes, it may be further subdivided using 4th and 5th digits. And you can see that by the little number. There'll be a little box with a 4th or 5th digit requirement by the actual code. And let's move right along. So we can go to 3, code or codes from A00.0 through T88.9, and then comma to our Z codes. The appropriate code or codes from these categories must be used to identify diagnosis, symptoms, conditions, problems, complaints, or other reasons for the encounter visit. So that's just telling us that those are the codes that we'll use for diagnosis, symptoms, conditions, problems, complaints, or other reason for the encounter visit. We have additional codes for reporting purposes that we've kind of covered a little bit, but we'll really start to learn more once we get into our book, like our why codes. And our why codes are our external causes. So when you see people talking about becoming a medical coder and using those funny little pictures like, struck by a pelican for the second time, those are external cause codes. Those are why codes. And so those aren't included in this description here. So moving down to 4, signs and symptoms, and hopefully you're following right along in your ICD-10 book and your guidelines section, so you can just easily follow along. These are directly from your guidelines in your ICD-10 book. So signs and symptoms. Signs and symptoms are codes that describe symptoms and signs as opposed to diagnosis. So when you think about a sign and symptom, immediately you can think strep throat, sore throat. So strep throat is the actual condition, while a sore throat is the symptom of a strep throat, right? So for outpatient guidelines versus inpatient guidelines, reporting rules are different. For outpatient guidelines, we do not code signs and symptoms if we have the actual condition. If we don't have strep throat documented, we can code the sore throat. But if we have strep throat documented and a sore throat documented, we wouldn't code both of those in an outpatient setting. Inpatient has different rules. And when we cover our inpatient coding guidelines, we'll get into that. They don't have too many different rules, but that's one of the big ones. In an inpatient setting, there are times you will code signs and symptoms. Okay, so moving along, and actually this is a good point here. Chapter 18 of ICD-10, that chapter is called Symptoms, Signs, and Abnormal Clinical and Laboratory Findings Not Elsewhere Classified. And the code range is that R00.0 through R99. And that contains many codes for symptoms. So when you see a code that begins with an R, you can automatically in your mind think, oh, I wonder if this is a sign and a symptom of something else, if I should even be coding this. So that's a good flag for you for test-taking purposes. Conditions that are an integral part of the disease process, number 5. Signs and symptoms that are associated routinely with the disease process should not be assigned as additional codes. We just covered that. Again, in the inpatient setting, that's different. And once we get into inpatient guidelines, we'll really cover that. Multiple coding for a single condition. So in addition to etiology and manifestation convention, which I will cover in greater detail too, but we went over a little bit in our last presentation. In addition to etiology and manifestation convention that requires 2 codes to describe a single condition that affects multiple body systems, use additional code notes are found in the tabular list at codes that are not part of an etiology manifestation pair, where a secondary code is useful to fully describe the condition. So if you're under your codes, if you see a use additional code, it indicates that a secondary code should be added. And they give us an example here in our guidelines. Bacterial infections that are not included in chapter 1, a secondary code, category B95, strep, staph, and enterococcus as the cause of disease classified elsewhere, or B96. So it's letting us know under that code. And if you want to just go to B95 and look at it, you'll see the description of the code itself. And a use additional code note will normally be found at the infectious disease code, indicating a need for organism code to be added as a secondary code. And this is a very common scenario where you would see use additional code. When you have that infection and then you need to describe what the infection is, that would be a use additional code. And as we get into the actual chapter-specific coding guidelines. We have coding examples. We'll look them up as we go along. Code first notes are under certain conditions that are not specifically manifestation codes, but may be due to an underlying cause. When there's a code first note, and we have an underlying condition present, we would code that underlying condition too. And it should be sequenced first. So you can see that that's right there. Code, if applicable, any causal condition first, and we're right here on our guidelines. This indicates that this code may be assigned as a principal diagnosis when the causal condition is unknown or not applicable. Sorry for all the background noise. We have animals and kids, so I apologize for that. Moving right along to 8, we have acute and chronic conditions. If the same condition is described as both acute, subacute, and chronic, and separate entries exist in the alphabetic index at the same indentation level, code both and sequence the acute code first. So basically what that's saying, if there is a specific diagnosis for acute and chronic conditions, you would code both if there's not a combination for them. And we'll look into some examples of that. I know that can sound a little confusing. Combination code. A combination code is a single code used to classify 2 diagnoses. So either a diagnosis with a manifestation or a diagnosis with an associated complication. And so you can think of like many of our diabetes with their manifestation codes in ICD10 are now 1 code. So like diabetes with neuropathy used to be 2 codes. Diabetes with neuropathy now is 1 code. And so that's a single code used to classify 2 diagnoses. And we'd assign only combination code when that code fully identifies the diagnostic conditions. Moving to 10, we have sequela or late effects. We talked about this a little bit. The sequela is a residual effect, a condition produced after the acute phase of an illness or injury has been terminated. So the big sequela that, a very common example is stroke, a CVA. So we have late effects of CVA. So we had the stroke in the hospital, 6 months later we're having hemiparesis. That hemiparesis and it's due to the CVA. That hemiparesis is a sequela of the CVA, so it would be considered a late effect. And so it really talks about here under these sequela guidelines, there's no time limit on when sequela code can be used. The residual may be apparent early, such as cerebral infarction, which is a stroke, or it may occur months or years later, such as that due to a previous injury, right? Examples of sequela include scar formation resulting from a burn, deviated septum due to a nasal fracture, and infertility due to tubal occlusion from old tuberculosis. And coding of sequela generally requires 2 codes sequenced in the following order. The condition or nature of the sequela is sequenced first, and the sequela code is sequenced second. An exception to this guideline are those instances where code for sequela is followed by a manifestation code identified in the tabular list, or the sequela code has been expanded to include the manifestation. And the code for the acute phase of an illness or injury that led to the sequela is never used with a code for that late effect. So what that's saying is you had the stroke, now you have the sequela of the stroke, the hemiparesis. When you're coding hemiparesis, late effect, you'd never code the stroke with that, the current stroke. So you would just code late effect of the stroke and the hemiparesis, not the actual stroke, because then it would be like you're having an acute stroke every time you went in and got treated for your hemiparesis. Impending or threatened condition. So you code any condition described at the time of discharge as impending or threatened as follows. If it did occur, code as a confirmed diagnosis. If it did not occur, reference the alphabetic index to determine if the condition has a subentry for impending or threatened and also reference main term entries for impending or threatened. So if you go to your ICD-10 book now and you look up impending in your index, you'll see a list of conditions that can apply to. So you can look up impending or threatened, and also reference and then see any subterms that are underneath there. And you would know which conditions can code when we have an impending or a threatened diagnosis. And I'll just give you a second to do that if you're following along in your book. And if you have any additional questions about that impending or threatened, just email us and we'll let you know. We had a question come across regarding the coding of HIV and AIDS, and we'll have time to get to that. That's our first section in our chapter-specific coding guidelines. So hopefully you saw the impending and threatened diagnosis in your index. We're going to move along to reporting same diagnosis more than once. Each unique ICD-10 diagnosis code may be reported only once for an encounter. This applies to bilateral conditions where there's no distinct code identifying laterality or two different conditions classified to the same ICD-10 CM code. So this is just saying, you know, if you have a condition where it affects both sides, so it's bilateral, and there's only one code for it, and that code doesn't reference left or right or bilateral, you would only code that diagnosis once. You wouldn't code it twice for each side. If it's exactly the same code, you only use it one time. With that too, you wouldn't code a left if you have a code for something on the left side and the right side. If there's a bilateral code for that, you would not code both the left and the right. You would just use the bilateral code. Sorry about the noise. Documentation for BMI, non-pressure ulcers, and pressure ulcer stages. For the body mass index, you're going to hear that referred to as BMI. Depth of non-pressure chronic ulcers and pressure ulcer stage codes. Code assignment may be based on medical record documentation from clinicians who are not the patient's provider. So this is a big one that was added into the guidelines because a lot of times dietitians or even MAs would document the BMI, and they wanted to make sure that, you know, that it's known that it doesn't have to be a provider or another qualified healthcare practitioner who is documenting that BMI. It can be a nurse, it can be an MA, but the associated diagnosis that goes along with that BMI, so either overweight or obesity, that still has to be documented by the provider or qualified healthcare professional. But the BMI can be documented by a dietitian or an MA, while the actual diagnosis that correlates with the BMI, whether it be overweight or obese or morbidly obese, that has to be documented by the provider. BMI code should only be reported as secondary diagnosis. As with all other secondary diagnosis codes, the BMI code should only be assigned when they meet the definition of a reportable additional diagnosis. And that's in another section that we can cover that. Moving to syndromes. Follow the alphabetic index guidance when coding syndromes. So in the absence of an alphabetic index guidance, assign codes for the documented manifestations of the syndrome. Additional codes for manifestations that are not an integral part of the disease process may also be assigned when the condition does not have a unique code. So when you don't have first you start at the index if you have something documented as a syndrome, and if it's there, if the term that's being used is there, then you can code that. If not, you can code any of the manifestations or the symptoms that are associated with that. Borderline diagnosis. If a provider documents a borderline diagnosis at the time of discharge, the diagnosis is coded as confirmed unless the classification provides a specific entry. And an example of that is borderline diabetes. So if you were to go to diabetes in your index and then look up borderline, there's a specific code for there. Since borderline conditions are not uncertain diagnosis, no distinction can be made between the care settings. So whether they are inpatient versus outpatient. Whenever the documentation is unclear regarding borderline conditions, coders are encouraged to query for clarification. And so, of course, this applies if you're working in a coding setting where you can get clarification and you can query a provider. Lots of coders don't even work necessarily for the provider, so they wouldn't be able to do that. If there's ever any doubt of whether you should code something or not, just don't code it. Use of sign, symptom, unspecified codes. Sign, symptom, and unspecified codes have acceptable, even necessary uses. And while specific diagnosis codes should be reported when they are supported by the available medical record documentation and clinical knowledge of the patient's health, there are instances where signs and symptoms and unspecified codes are the best choices for the diagnosis. So here's an example. If a diagnosis of pneumonia has been determined, but there's not a specific type of pneumonia, then you would just default to the unspecified pneumonia. If it's not documented, you can't code it. And unspecified codes should be reported when they are the codes that most accurately reflect what is known about the patient's condition at the time of the particular encounter. Okay, so now we're going to get into some chapter-specific coding guidelines. And we're probably going to cover this through the next couple of WebExes because we have some examples we're going to look up along the way, okay? So we're going to start, first of all, in addition to our general coding guidelines, there are guidelines for specific diagnosis and conditions in the classification. Unless otherwise indicated, these guidelines apply to all healthcare settings. So we're going to start with our HIV. So human immunodeficiency virus, HIV infections. And there's a lot of guidelines that go along this. It's really important that we make sure that we are only coding confirmed cases of HIV. And there are rules that apply to whether HIV is HIV or AIDS. And so we'll see that. So our first note, we code only confirmed cases. So we code only confirmed HIV infection illness. This is an exception to the hospital inpatient guidelines. So hospital guidelines are different, and once we cover that, we'll get into that. But for our purposes today, we only code confirmed cases of HIV. Confirmation does not require documentation of positive serology or culture for HIV. The provider's diagnostic statement that the patient is HIV positive or has an HIV-related illness is sufficient. So I want to look up a code here so we can see. So a patient is admitted with anemia with possible HIV infection. Okay, so how would we code that? Well, let's see really quick. Okay. Okay, so I'm just going to use my whiteboard for this. Okay, so patient admitted with anemia with possible HIV infection. So if we look at that, immediately we see the patient's admitted for anemia, but with a possible HIV infection. So according to our guidelines, we would only code the anemia. Oops. Sorry about this. I'll have to practice with this whiteboard, but it's really cool. D64.9. We would not code the HIV because it is documented as possible. So back to our guidelines. Our next part, 2, of HIV infections is number 2, selection and sequencing of HIV codes. So our first example, we have patient admitted for HIV-related condition. If the patient is admitted for an HIV-related condition, the principal diagnosis should be B20, HIV disease, followed by the additional diagnosis codes for all HIV-related conditions. So if you have, let's see. So basically, this is telling us 2 things. First, if the patient is admitted for an HIV-related condition, right away that's going to change the HIV code. So it's going to be, there's 2 HIV codes, and we'll get into the difference between those in just a moment. But for B20, that's confirmed HIV. And so we would sequence our B20 first, followed by any additional codes for reported HIV illness. And I'm going to give you 2 codes right now, and you guys can look them up later so you can see an example, because this is a little bit difficult to use. So until I master it, I'm just going to give you guys 2 codes. So there's our B20, and there's our B59. And since this is recorded, you can always go back and look these up later. So B20 and B59. B20 is our HIV disease, and B59 is an example of an HIV-related condition. Okay. So if a patient is with HIV disease admitted for unrelated condition, okay, so if a patient with the disease is admitted for an unrelated condition, such as a traumatic injury, like you break your elbow or you break your leg, the code for the unrelated condition should be the principal diagnosis. So you see that's opposite as what we just learned. So if the patient is admitted for unrelated condition to the HIV, then that unrelated condition would be sequenced first. Other diagnosis would be B20, followed by additional diagnosis for any HIV-related conditions. So we'd have the traumatic injury, the breaking of the elbow first, then we'd have the HIV, and then we'd have any other conditions. Our next HIV guideline, whether the patient is newly diagnosed or has had previous admissions encounters for HIV conditions is irrelevant to the sequencing decision. So it doesn't matter if the patient's newly diagnosed or not. It doesn't change the rules we just covered. Asymptomatic human immunodeficiency virus. So asymptomatic means we don't have any symptoms. So asymptomatic is Z21. And this is important to remember. So Z21, asymptomatic human immunodeficiency. So we have about 10 minutes left. So I just got a little flag. So that's why I'm sharing it. So Z21, asymptomatic human immunodeficiency virus infection. It's applied when the patient, without any documentation of symptoms, is listed as being HIV positive, known HIV, HIV test positive, or similar terminology. And we would never use this code if AIDS was documented in the medical record, or if the patient is treated for any HIV-related illness, or is described as having any condition resulting from his or her HIV positive status. We use B20 in these cases. That's very important, so make sure that you highlight that. If it's documented in the medical record, AIDS, HIV-related illness, or having any conditions related to HIV positive status, it's always going to be B20. Once a patient has developed any of these illnesses too, or has been documented as having AIDS, they'll never be Z21 again. Once they move from Z21 to asymptomatic HIV, to having any conditions of HIV, or being documented as having AIDS, they'll never be Z21 again. They'll always be B20. Now, from a coder perspective, you can only code what you see. So if there's any documentation in the medical record of an HIV-related illness, even if they're asymptomatic, you would only code the B20. So moving along, patients with inconclusive HIV serology. Patients with inconclusive HIV serology, but no definite diagnosis or manifestation of the illness, they may be assigned a code R75, inconclusive laboratory evidence of HIV. Remember what those R codes are. Those R codes are, they flag us for signs, symptoms, and abnormal clinical findings. So if they have an inconclusive test result, they would have an R75 diagnosis. Previously diagnosed HIV-related illness. Patients with known prior diagnosis of an HIV-related illness should be coded to B20. So this is what we just covered. Once a patient has developed an HIV-related illness, the patient should always be assigned code B20 on every subsequent admission encounter. Patients previously diagnosed with any HIV illness, B20, should never be assigned that R75 or Z21, asymptomatic human immunodeficiency virus infection status. So once you have any condition resulting from your HIV infection, or if you've ever had AIDS documented in the medical record, you'll never be that Z code again or that R code either. G, HIV infection in pregnancy, childbirth, and the periperium. This is a word that no matter, I always end up having to present, and for some reason this comes up frequently, and it's always a tongue twister for me. So during pregnancy or childbirth or the periperium, a patient admitted or presenting for a healthcare encounter because of an HIV-related illness should receive a principal diagnosis code of 098.7. So this is important too. So if there's a pregnant woman or somebody's going through pregnancy or childbirth and they have an HIV-related illness or HIV, it's very important that we sequence that principal diagnosis, the first listed diagnosis of 098.7, followed by B20 and the code for the HIV-related illness. Codes from chapter 15, and you can highlight this, although we'll cover it when we get into chapter 15. Codes from chapter 15 always take sequencing priority. Patients with asymptomatic HIV infection status admitted or presenting for a healthcare encounter during pregnancy, childbirth, or the periperium should receive codes of 098.7 and Z21. Okay, and now our last HIV-related coding guideline, encounters for testing for HIV. If a patient is being seen to determine his or her HIV status, use code Z11.4, encounter for screening for human immunodeficiency virus. Use additional codes for any associated high-risk behavior. If a patient with signs or symptoms is being seen for HIV testing, code the signs and symptoms. An additional counseling code, Z71.7, HIV counseling, may be used if counseling is provided during that encounter. When a patient returns to be informed of the HIV test results, and the test result is negative, you use that Z71.7 HIV counseling. If the results are positive, you can just read the previous guideline and assign codes as appropriate. So if it's a positive HIV test result with and it's asymptomatic, so no symptoms, no conditions, then we know we would code our Z21 code, right? Okay, so we're going to stop going through our this part of our guidelines now. We have a few more minutes. We have about 3 more minutes, but I'm just going to pull something up. Let's see. Okay. Oh, sorry. Okay. Well, I don't have it available, but I will post it. So I have a sheet with examples of everything that we covered. And so we can You can access those on the codingspot.com under current students, and we'll send an email out as soon as this is uploaded. For some reason, last week's presentation didn't upload properly, so we've corrected that problem, and that presentation will be refilmed. It was the section before, and you'll be able to access that too. So thank you for joining us, and any questions about what was covered today, please just send out an email, and any questions moving forward, please just reach out and we'll answer them as soon as we can. Have a great day.